acute rise in vascular tone, it can raise the blood pressure instantaneously. And increased after load, this vascular tone increases the pressure. So when cardiac contracts, heart contracts, or to cause the stroke volume out, then it faces more resistance for this cardiac output. And ultimately, the pressure increases inside the heart. And there may be left heart failure. Initially, there may be increase in the thickness of the wall of the left ventricle, and ultimately it may cause left ventricular failure. And this left ventricular failure may cause edema in the pulmonary vessels also. And this edema in the pulmonary vessels is called flash pulmonary edema.
পেজ ডাউন হচ্ছে না আমিনুল ভাই?
পড়াটা যাচ্ছে না।
পেজ ডাউন, ডান পাশে ওই যে কি আপনার কি গুলার মধ্যে দেখেন, পেজ ডাউন বা ডাউন ডাউন কি যেটা ডাউন অ্যারো যে কিতে দেওয়া ওইটা চাপ দিলেই তো যাওয়ার কথা।
যাওয়ার কথা কিন্তু যাচ্ছে না।
তো এই যে আইটির এই যে হেল্প করছে তাকে বললে মনে হয় করতে পারবে।
সে মনে হয় কন্ট্রোল করতেছে। চেঞ্জ হতেছে না।
চেঞ্জ হচ্ছে না স্যার, জাস্ট কাইন্ডলি আপ ডাউন ডাউন এরো কি দেন স্যার?
ডাউনে দিচ্ছি তো যায় না।
আমার মনে হয় যে ওই আইটি স্পেশালিস্ট যিনি আছেন উনি অন রিকোয়েস্ট স্লাইড ডাউন করেন।
এলাও করেন স্যার।
এলাও করা আছে না?
স্যার আমি দিচ্ছি স্যার।
নেক্সট, থ্যাংক ইউ
স্যার। আপনি নেক্সট বলেন স্যার, তাহলে আমি বুঝতে পারবো স্যার।
আচ্ছা, ঠিক আছে। Intracranial event. This is changes in the brain. What happens? Because of the atherosclerosis, because of the deposition of lipid material in the vessel, the lumen of the vessel is narrowed, thereby giving less blood to the brain. That means less oxygen to the brain. If there is ischemia in the brain stem, that will cause increase the blood pressure. Even fluid overload can cause increased blood pressure in the younger patient without the onset of peripheral edema and originate from myocardial dysfunction or impaired renal clearance. If we introduce or inject fluid in a younger person, then if there is abnormality in the myocardium in diastolic phase, or if there is renal impairment of excretion of fluid, then that condition can cause a rise of blood pressure in the younger patient without causing any edema in the leg. Next. Underlying medical problems: renal disease, spinal injury, pheochromocytoma, pregnancy-induced hypertension, and preeclampsia. If we consider the kidney may be the cause of hypertension, or hypertension may affect the kidney. If we consider the kidney, if there is glomerulonephritis, or if there is ischemia in the preglomerular vessels, that can cause ischemia, sometimes hyperperfusion, say for example diabetes mellitus. If the perfusion in the kidney maybe more, then this can also cause damage to the glomerulus. In any way, if there is damage to the glomerulus or in the tubules, that can cause raise of the blood pressure. Even spinal injury can affect the nerves. Say, for example, if it involves the autonomic nerves, that can cause the raise of blood pressure. In pheochromocytoma, this is actually a tumor. In this case, I will discuss it later on. In pregnancy-induced hypertension, in pregnancy, there is fluid secretion of estrogen, and this estrogen can contain volume of fluid in the body, thereby causing edema in the pregnant lady. And because of a high volume of this fluid, this can also raise the blood pressure. And when a pregnant woman faces this increase in blood pressure, the condition may be worse. There may be preeclampsia, even eclampsia. Primary cardiac problems like myocardial ischemia, heart failure, and aortic dissection can all present with hypertension. This myocardial ischemia can cause the cardiac involvement, and it can cause even heart failure in future. And aortic dissection, this is also effect of hypertension, and it causes usually in the aorta, either descending aorta or the abdominal aorta, and this is a grave condition. Drugs sometimes, amphetamine or cocaine, can cause the increase in blood pressure. Pathogenesis of hypertension. We can divide the pathogenesis in different sections. Say, for example, renal dysfunction, peripheral resistance, basal tone, endothelial dysfunction, autonomic tone, insulin resistance, and neurohormonal factors. All these factors can cause increase in the blood pressure. Renal dysfunction, if there is excretion of fluid is less, this usually occurs in either acute or chronic renal failure. This can ultimately cause increase in blood pressure. If there is increase in peripheral resistance, it may also cause the rise of blood pressure. And basal tone also cause the increase in blood pressure. Endothelial dysfunction, it has two functions. One is it secretes the nitrous oxide, and this causes vasodilatation. But if this function is hampered or impaired, then this vasodilation cannot occur, and reflexly it causes the increase in blood pressure. Another is endothelin, secreted by the endothelial cell, and this can also cause constriction of the blood vessels, and which can cause a rise of blood pressure. Autonomic tone is actually sympathetic discharge in different emergency condition of the body. This sympathetic discharge is more, and this causes massive vasoconstriction throughout the whole body, which can raise the blood pressure. Insulin resistance, it is actually part of metabolic syndrome. When there is obesity, there is hypertension, there is dyslipidemia, and also this obesity and dyslipidemia can cause insulin resistance. And these components in together causes rise in blood pressure. Neurohormonal factors are also effective. That is neuron, that means autonomic nervous system, and humoral many factors can cause constriction of the blood vessels and ultimately raise the blood pressure. In large artery, internal elastic lamina is thickened, smooth muscle hypertrophy, and fibrous tissue deposited. It causes in a different situation. When there is thickening of internal elastic lamina, it can cause the raise of blood pressure. If there is a hypertrophy of the smooth muscle, this can individually cause rise of blood pressure. And if there is fibrinoid necrosis or necrosis in the blood vessel due to any cause, this will be replaced by fibrous tissue. When the fibrous tissue is deposited, the vessels become thickened, and this thick vessel is not compliant, and thereby blood pressure is raised. In small artery, there is hyaline arteriosclerosis. That means the hyaline, this is the degenerated tissue, and this is replaced by fibrous tissue and cause the thickening of the vessels. This is called arteriosclerosis. It occurs usually in the older ages. That's why the pressure in the older ages gradually increases. Risk factors for hypertension, non-modifiable, age and ethnicity. There, it is seen that when an African people or Japanese people go to the America, in course of time they develop hypertension. This is the ethnic effect of the blood pressure. And sometimes age, in when person becomes elderly, then there is development of blood pressure, raised blood pressure, because of two things. One is atherosclerosis and another is arteriosclerosis. This combinedly raise the blood pressure in elderly. Modifiable risk factor, that is high salt intake. In our country, in the rural area, many people take extra salt in their taking main meals. They cannot take food without this salt. And for a long time, if anyone can take salt, this salt is actually sodium, and this sodium is encircled by water. So if any person take more than required amount of salt, this will also conserve water, and this sodium, chloride and water can raise the blood pressure. So we have to inhibit, or we have to um, ask to the person or hypertensive people who take table salt or extra salt in their main meal to decrease or minimize, or to null it for future safety. Heavy consumption of alcohol. This is not a problem in our country, but in some patient it may happen. If anyone can take beans of alcohol in a day, that can raise the blood pressure. Obesity also cause a raise of blood pressure. Obesity, usually obese person accumulates fatty tissue in the body in different parts, but mainly in the abdomen. This abdominal obesity is related to this hypertension. Those who have abdominal adiposity is more, they are more prone to develop hypertension. Lack of exercise, that is sedentary lifestyle. Many of our high-ranking people, many of our businessmen, they spend most of their time in sitting position. This sedentary lifestyle can cause not only hypertension, but cause many problems in the health. So we should also discourage this. Impaired uterine growth. When there is impaired uterine growth, this baby may be usually low birth weight, and when they become adolescent or adult, it is seen that they develop hypertension. 95% cases are essential or primary hypertension. That means in that cases, we do not usually cause any underlying cause for this hypertension, but 5% are secondary to a specific disease. These are the secondary causes of hypertension. We have already discussed alcohol, obesity, and pregnancy. We have also discussed renal disease, but renovascular disease that cause renal stenosis. And this is due to fibromuscular dysplasia. The flow to the kidney is less, and this incites the renin-angiotensin system. And because of stimulation of this system, there is vasoconstriction and there is preservation of fluid by the kidney from the tubules. This combinedly cause the hypertension. Polycystic kidney disease also can cause hypertension in the adult or late life, because these cysts almost occupy most of the kidney substance, and because of their pressure, the glomerulus are damaged, and the number of the glomerulus, active glomerulus, be less. These are the causes of raised hypertension. In endocrine causes, that is pheochromocytoma, that is the adrenal tumor. In this case, catecholamines are secreting more, and this causes the vasoconstriction, thereby raising the pressure. In Cushing syndrome, usually it is seen that the ACTase secreted by the tumor of the pituitary gland can cause in raised hypertension. These ACTase may also be secreted from the cancer, and it may also be secreted from the non-pituitary portion of the body. That is, sometimes bronchial asthma can cause secretion of this ACTase, and this ACTase can cause the ultimately hypertension and obesity. This is called Cushing syndrome. Sometimes the iatrogenic steroid use can also cause this syndrome. Primary hyperaldosteronism, that is Kuhn syndrome. In this case, there is excessive secretion of aldosterone from the adrenal gland. This aldosterone can preserve the sodium from the tubules in the kidney and also excrete potassium. So if we find excessive and hypernatremia with hypokalemia, this is a feature of aldosteronism. And this aldosteronism, this conservation of fluid by the kidney can cause hypertension. Glucocorticoid suppressible hyperaldosteronism, this is same. Hyperparathyroidism, we also see that if there is increase in the calcium level in the blood, the patient also suffers from hypertension. And this increase in calcium is usually caused by the hyperparathyroidism. Mainly primary hyperparathyroidism can cause rise of calcium level as well as the rise of blood pressure, that is hypertension. In acromegaly, we also get the hypertension in the acromegalic patient. Primary hyperthyroidism, this case, it is usually seen that the diastolic hypertension is gradually increased in hypothyroidism. But in case of thyrotoxicosis, it is seen that systolic hypertension is more. So there is increase in the pressure in thyroid diseases. Congenital adrenal hyperplasia, Liddle syndrome, and 11 beta hydroxy dehydrogenase deficiency all causes adrenal hyperplasia, and this hyperplasia can cause excessive secretion of the adrenal hormone, thereby increasing the blood pressure. Drugs and some drugs can also increase the blood pressure. Coarctation of this is another case. It is a congenital condition. Sometimes there is coarctation of the aorta in different position. But if there is coarctation, the blood flow to the upper and also lower limb, mostly in the upper limb, there is decrease blood flow, and it causes hypertension. Accelerated hypertension. This is if there is sudden rise of blood pressure, very high, say for example, more than 200 systolic and more than 110 diastolic. This is called accelerated hypertension. Sometimes patients come with this in our chamber, and we have to deal with this. In that case, we have to consider the organs. Say, for example, brain, kidney, eye. We have to check this. If there is involvement of the organ, either stroke or renal failure or fibrinoid necrosis, this type of changes, then it is called malignant hypertension. If we do not get any change in the organ, then we call it accelerated hypertension. Both these are medical emergencies, and we treat this patient very cautiously and seriously so that their life can be saved. And where the vessels are necrosed, usually caused by fibrinoid necrosis. In that place, the place is raw, and that is the site of intravascular thrombosis. This thrombosis sometimes can also cause ischemia and gangrene in the distal part. High blood pressure, rapidly progressive organ damage, usually retinopathy or kidney. We can assess the kidney either by examination of the urine or bedside clinic examination whether there is proteinuria or not. And it also causes hypertensive encephalopathy. That means there is local regulation system of the blood pressure, but when this is damaged, then there is encephalopathy in the brain. So this accelerated hypertension may cause kidney damage, may cause heart failure, may cause encephalopathy, even may cause retinopathy and blindness. So we should be cautious about this accessory and accelerated hypertension. If we see the retina, that is by ophthalmoscopic examination, in the upper field, there is hyperemia and there is woolly exudate. And fundus is not properly seen. That is, so if these three findings are present, fundus is blood, there is hemorrhage, and there is woolly deposit. This is the change in accelerated hypertension or malignant hypertension. But if we find serious bloody appearance of the retina, then it can be due to retinal venous thrombosis. So this we have to examine the fundus if the patient is hypertensive. Even if there is accelerated hypertension, we should examine the fundus regularly. Pathological consequences of hypertension in heart. What happens? If the heart contracts every time against the high blood pressure, ultimately there will be left ventricular hypertrophy. By this hypertrophy, heart try to overcome the hypertensive workload, but ultimately it fails and cause chronic heart failure. Atherosclerotic coronary artery disease. When there is atherosclerosis, either in obese person or in elderly person, this atherosclerosis can cause the narrowing of the coronary artery. This narrowed coronary vessel cannot supply the adequate amount of blood to the myocardium, which is always active by constricting and to cause struggling output. So when there is atherosclerosis, and if the supply of blood and nutrition is less, then cardiac muscle may be damaged. This is called myocardial infarction. Microvascular disease, this also happens during the either partial deposition of the lipid or also vasoconstriction. Both can cause this microvascular disease. Sometimes heart responds with cardiac arrhythmias, and also there is diastolic dysfunction if there is left ventricular involvement by hypertension. In brain, there may be multiple lacunar infarct. In this case, patient may be disoriented, patient may be pre-comatose, patient may lose their balance, may fall down from a sitting or standing position, and ultimately the effect will be less and this patient may recover almost completely. But if there is multiple lacunar infect, that can cause the damage to the brain and ultimately they suffer from uh, cognitive impairment. And if there is large hemorrhage or large ischemic stroke or multiple infarct stroke, ultimately these patients suffers from cognitive impairment or dementia. Hypertensive encephalopathy, it may cause when there is impairment of the local regulation of blood pressure in the brain that can cause hypertensive encephalopathy. In kidney, both a target and a cause of hypertension, I have already mentioned, diminished capacity to excrete sodium. If kidney cannot excrete sodium properly, then it will be accumulated in the body. We have also already mentioned sodium cannot accumulate singly. It remains covered by water. So when there is retention of sodium, there is retention of excessive volume of fluid. This causes rise of blood pressure. Excessive renin secretion. If there is reduced blood supply to the kidney, this can cause renin secretion, excessive renin secretion, and this excessive renin secretion can cause renin angiotensin system stimulation, and this can cause vasoconstriction plus fluid retention, thereby causing hypertension. Sympathetic overactivity, this also can associate or cooperate this development of the hypertension. Glomerular injury, if the glomerulus are gradually decreasing number by disease, or if they become atrophied, then they cannot perform their proper function, and ultimately retention of fluid can cause the hypertension. Peripheral arteries are also affected by hypertension. Usually there is atherosclerosis in the peripheral vessels. If there is atherosclerosis, if we palpate the vessels, then we will find there is sluggish flow. And initially there is ischemia, and if these ischemic vessels be injured, there may be thrombosis. If there is thrombosis, the flow will be completely obstructed and there will be gangrene in the distal part. So if there is loss of shining, loss of hair, there is color change, there is a reduced feeling of impulse in the lower limb, we should suspect there is hypertension, and there is also atherosclerosis, and the peripheral arteries are affected. In obesity, there is well-documented association between obesity and hypertension. Obesity, usually lipid material are deposited in different parts of the body, either in the back of the neck, maybe in the buttock, maybe in the belly, and may also be in other parts of the body. But the deposition of fat most likely occurs and most predilecting area of the abdomen. And this is called abdominal adiposity. And this abdominal adiposity is mostly concerned with the increased blood pressure. This is also involved in the metabolic syndrome. Metabolic syndrome, this is hypertension, dyslipidemia, frequently occur together with insulin resistance. When there is hypercholesterolemia or dyslipidemia, this will increase the insulin resistance. That means the insulin cannot work in the peripheral tissue, and the uptake of sugar by the peripheral tissue is less. In turn, this will also increase the lipid substance. So this is a condition which can raise the sequentially and ultimately these factors combinedly called metabolic syndrome. Renovascular hypertension, this is due to fibromuscular dysplasia. When that occurs, the lumen of the renal artery is reduced or minimized or narrowed down. This narrow vessel cannot pass adequate amount of blood flow to the kidney, and the glomerulus also suffers. So glomerular damage, glomerularitis, and glomerular atrophy can cause, and this can cause the accumulation of fluid and ultimately results in hypertension. This also activates this low flow of blood to the kidney, also activates the renin-angiotensin system. This can cause hypertension. We are in the last part of the my lecture, pathologic consequences of hypertension in primary aldosteronism. It is already described. This is caused by the adrenal gland when there is secretion of aldosterone is more from the adrenal gland. This will cause the hypertension. Cushing syndrome and pheochromocytoma, these are already told. There are some other causes which can also cause a rise in blood pressure, say for example, obstructive sleep apnea. This actually increases the sympathetic activity. Coarctation of the thyroid disease, hypercalcemia, and drugs. We have already described this. Obstructive sleep apnea. Many patients suffers from this, and because of this sufferings, their sympathetic system becomes overactive and causes hypertension. When these patients use or apply CPAP, they can sleep soundly, and their blood pressure reduces to some extent. Thank you. Thank you all. Have you got any questions?
Thank you, sir. Thank you for the brilliant presentation. Sir has taken much time and worked hard to make this presentation within a short time. So our heartfelt gratitude to Honorable Sir. So the floor is now open for question answer. So any question regarding hypertension, concomitant pathologies, or anything, please share with us. Anyone can unmute himself and participate. Sir, Professor Rafiqul Islam sir আছেন স্যার কাইন্ডলি স্যার শুরু থেকে আমাদের সাথে ছিলেন এখন কি আছেন স্যার?
হ্যাঁ সালামালাইকুম। আমি আসলে ভোরে চলে যাব তো গোছগাছ করছি, তো আমি
Sir,
চ্যাটবক্সে
any comments sir regarding today's presentation, sir?
আমি লিখে দিছি, presentation is quite brilliant, slow, deliberate and exclusive, and obviously it will be very useful to the beginners, at least postgraduate trainees, so I could enjoy the subsequent sessions, but I am in hurry.
Thank you, sir. Thank you so much, sir, for being with us. Professor M.A. Sattar sir ke dekhi participant list hai. Honorable Head Department of Medicine of Chittagong Medical College. Sir, welcome, sir, to our master class.
Assalamu alaikum. Thank you.
Sir, what is how you deal your hypertension, your hypertensive patients? Any tips for our junior? এখানে আসলে খুব junior কেউ নেই. Everybody is life member of Bangladesh Society of Medicine, but still, any tips and your practical experience dealing with your hypertensive patients?
Thank you, Mongni. Actually, whenever we talk about hypertension, the important things it is always we have to keep in mind that we have to confirm the blood pressure, particularly at the initial stage. Say for regarding the diagnosis of hypertension, so it need to be confirm the diagnosis with repeated measurement. We know, all of you know about it. And particularly for the junior, we should emphasize on the issue that if a single reading of blood pressure doesn't constitute to declare a patient a hypertensive, before that we have to be ensured that it is, of course, it is a persistently raised and repeated measurement shows it raised. And regarding the management of hypertension, one thing is important, that what we see in clinical practice, most of the time, a patient is being given with a low dose of bisoprolol, say for as a beginning in the case of hypertension, say for in diabetes and others in different situations. We know that in such a situation, unless there is a compelling indication for beta blockers, most of the time it should not be. But it's a common practice. So whenever we see a patient to begin with an antihypertensive drug, we must not forget that what is the compelling indication and which drug should be given in which situation. Because we have to keep in mind that we should not be myopic in treating the hypertension. Most of the time, I say to my patient, because look, gentlemen, I am not giving you treatment for today. I am looking for you. I wish that you be healthy, remain healthy after 30 years, 20 years. So for this, we need to treat the hypertensive patient to their target. And every prescription, and every patient should know their target. What should be the target? If during giving a prescription, during measuring blood pressure, if we say that, yes, as because you are diabetes, you are hypertensive, you need to take your hypertension pressure level less than 130/80. And we can write it on the prescription. And with every facilities, we know that you need to know the numbers. You not to know your numbers. That is your level, cholesterol level, your hypertension level, your LDL level, HbA1c level. So we have to educate our patient for a good hypertension management. And we know that the level of hypertension is being reduced, so that the sprint trial showed that the lowest the better. So I think most about treating to those level, most of our patient develops symptoms and say for vertigo and that. So it's very difficult for us to treat to that lower level of pressure. Of course, I enjoyed the class of Professor Rafiqul Islam sir, very nice.
Aminul Hoque sir was there.
Aminul Hoque sir is very keen, very clear, and he slowly delivered, so that it was very understandable. I enjoyed your class, sir. Thank you very much, and thank you, Mongni, for your.
Thank you, Professor Sadar, sir, for joining us. It's a very happy feeling for us in the master class that masters like you and others join, and we can share our thoughts with each other. So this is what the masterclass platform is. It is not only a teaching session or any other teaching class. Rather, it's a platform for exchanging our views and sharing our experiences as with each other of the Bangladesh Society of Medicine members for the betterment of our learning and to exert better treatment to our patients. Thank you, sir, for being with us. So we are almost at the end of our today's session. Any other further, any question or any sharing with us from the learned members? Anyone can unmute, or we will go.
Thank you, sir. আমি Dr. Rothin.
Dr. Rothin, thank you for being a persistent member and persistent participant of this master class. Please, Dr. Rothin.
থ্যাংক ইউ স্যার। আমি স্যারকে ধন্যবাদ জানাচ্ছি স্যারের খুব সুন্দর প্রেজেন্টেশনের জন্য। আসলে স্যার আমার কোনো প্রশ্ন নাই, আপনার আসলে এই প্রেজেন্টেশনের পরে কোনো প্রশ্ন থাকার কথা না। আমি স্যার একটা কমেন্ট বলছি যে আমরা আসলে রংপুরে হাইপারটেনশন নিয়ে অনেকগুলো কাজ করছি আমাদের শ্রদ্ধেয় জাকির হোসেন স্যারের হাইপারটেনশন অ্যান্ড রিসার্চ সেন্টারে। তো স্যার আমার কয়েকটা প্রশ্ন যে আমাদের অনেক হাইপারটেনসিভ যাদের ব্লাড প্রেশার কন্ট্রোল, তাদের লিপিড প্রোফাইল ভালো, ডায়াবেটিস নেই, কিন্তু হুট করে দেখা যাচ্ছে যে স্ট্রোক করে যাচ্ছে, হুট করে একটা একুট এমআইয়ের অ্যাটাক হচ্ছে। তো এখানে আহ, একটা একটা প্রশ্ন থাকে যে ইনস্পাইট অফ কন্ট্রোল বিপি, ইনস্পাইট হ্যাভিং নর্মাল লিপিড প্রোফাইল, এই পেশেন্টটা কেন স্ট্রোক করলো, কেন একটা ভাস্কুলার ইভেন্ট হলো। তো আমরা স্যার খুব রিসেন্টলি একটা গবেষণা করি হাইপারটেনশন রিসার্চ সেন্টারে, যেটা আমরা যে ব্লাড প্রেশার ভেরিয়েবিলিটি এখন বলা হয় স্যার, যেটা একটা খুব ইম্পর্টেন্ট, যে এই আমাদের যে ডে টু ডে ভেরিয়েবিলিটি, আওয়ার্স টু আওয়ার্স ভেরিয়েবিলিটি, পার্টিকুলারলি ডিপিং অ্যান্ড রিভার্স ডিপিং, এটা খুবই একটা ইম্পর্টেন্ট একটা ইস্যুস যে হাইপারটেনশনের ভাস্কুলার কমপ্লিকেশনসের জন্য। তো আমরা স্যার আমাদের একটা গবেষণায় দেখলাম যে আমাদের হাইপারটেনসিভদের 99%-এরই কোনো ডিপিং হয় না, এবং 34%-এর বরং রিভার্স ডিপিং হচ্ছে। এবং আমরা যখন এটা নর্মাল যারা নর্মোটেনসিভ তাদের সাথে কম্পেয়ার করলাম, তাদের দেখলাম স্যার যে সেম ইফেক্ট, যে 100%-এরই কোনো ডিপিং হচ্ছে না। তো আমার যেটা স্যার এখান থেকে মনে হয় যে আমাদের হয়তো আরো অনেক কাজের একটা অপরচুনিটি আছে, যে আমাদের যে পিপলদের আসলেই ডিপিং হয় কিনা, তাদের প্রফেশন, তাদের মানে লাইফস্টাইল, তাদের স্লিপিং আওয়ার, এগুলোর উপর আসলে এটা মানে কোনো প্রভাব আছে কিনা, এবং যার কারণেই আমাদের এত কমপ্লিকেশনস কিনা। কারণ আমাদের স্যার আরেকটা ইয়ে আছে যে 71% অফ দ্য হাইপারটেনসিভ পেশেন্ট ডাইড ডিউ টু কমপ্লিকেশনস অফ হাইপারটেনশন। তো এটা একটা স্যার আমার বলার ছিল। আরেকটা হচ্ছে স্যার যে আমরা সবসময় ডাইন হাতে প্রেশারটা মাপি। তো আমাদের স্যার এই একটা রিসেন্ট একটা আমাদের রিসার্চে দেখা গেছে যে আমাদের বাংলাদেশি পিপলদের মানে অধিকাংশদের লেফট হ্যান্ডে বিপি বেশি। তো এটাও হয়তো আরো মানে এটা আমাদের একটা গবেষণার অবজারভেশন, আরো হয়তো অনেক বড় অবজারভেশন স্যার আপনাদের আছে, যে আমরা আসলে সবসময় রাইট হ্যান্ডে প্রেশার দেখি, কিন্তু অ্যাকচুয়ালি তো যে হাতে বেশি পাবো সেই হাতেই দেখতে হবে। এই জন্য সবার আসলে, যেটা আমাদের শ্রদ্ধেয় সাত্তার স্যার বললেন, যে আমাদের সবার আসলে নিজেরটা জানতে হবে, যে আমার কোন হাতে প্রেশার মাপবো, আমার ব্লাড সুগার কত, আমার লিপিড প্রোফাইল কত, আমার এইচবিএনসি কত, আমার থাইরয়েড প্রোফাইলটা কি রকম। তো এই আর কি স্যার। থ্যাংক ইউ। আমার মনে হয় আজকে শেষ ক্লাস, যেটা আমাদের গোলাম মগনি মাওলা স্যার এর আগে বলেছিলেন। তো এই
Now we will have the last class the next Tuesday, 20th, and we are very happy to have the Honorable Director of NCDC, Professor Robin Amin sir, to conclude the hypertension season of this season of master class. Because hypertension is nationally dealt by Professor Robin Amin, so he will be taking the class.
Thank you. It will be a great event. Hope for the best. And thank you, sir. Thank you, Gulam Mogni Maula, sir.
মগ্নি,
Sir,
আমি একটু বলতে চাই ওর যে though the patients are taking regularly antihypertensive, but still there is a stroke or infection. There is two aspects. One is the pathological changes. It is a gradual one. Say, for example, in a patient of 60 years, if we find the atherosclerosed vessel, it may start even up to 30 years back. And for this long time, it gradually increases up to the pathological point of thrombosis or embolism. So we have to follow this patient throughout her life or his life to assess these changes in the atherosclerosis. It is gradually going forwards. Another thing, if we consider any drug, usually most of the antihypertensive drugs we take or we give singly, once in a day. Usually oral drug absorbed after 30 minutes. So the concentration of the drug in the blood is highest after taking the drug half an hour. And this when this drug enters into the blood, the metabolism will also start it, either by liver or by kidney or by any other organ. So if there is metabolism is ongoing, and when this drug durability after 20 hours, definitely the concentration will be less and the effect will be less. So no drug can control the blood pressure throughout the day. It is theoretically possible, but practically it is not possible. So two factors remains unsolved. One is going atherosclerosis and other one is 24 hours control of the blood pressure, which is not possible. So because of this unsolved, uncontrolled factor, ultimately, even the patient takes the drug regularly, the patient suffers from either stroke or MI. It is obviously the natural outcome of the disease.
Right, sir. You have rightly mentioned, sir.
Thank you, sir. Thank you for your explanation.
Right, sir. And obviously, there are many other factors that need to be explored by thorough research activities. And
Another thing is hypertension is a multifactorial matter. If there is insomnia, if there is excess anxiety, if there is depression, if there is overeating, if there is hurry, if there many factors can influence this hypertension. So day-to-day diurnal or even variation in time is always occurring in the person. And the ultimate defect is the deterioration of the condition. Thank you.
thank you, sir. Thank you, sir. So we are almost at the end of today's program, because discussion can be dragged whole night with hypertension. So dear participants, we are almost at the end of our season 1 of master class. The first session was on infectious disease. Second session was on diabetes, and the third session was on hypertension, which will be ended by the next class on Tuesday 20th. I hope maximum participants will be joining the ending class of this season. And after that, we have our annual conference coming, followed by Ramadan. So there will be a short break on master class. And after Eid, we hope that as per the direction of EC and Honorable President and Secretary General and the Scientific Chair, we will resume master class. So till then, good night and thank you. Thank you, Professor Aminul Hoque, sir, for
Thank
being
you.
so kind to deliver the class today. Thank you, sir. And
Thank
thank you all participants. Allah Hafiz.
Allah Hafiz.